Hi, this is Dr. Viral Parekh once again. Welcome back to YouTube channel of Kolkata Academy of Radiology. Here is another interesting case by Dr. Mayukh Bhattacharya, who is my colleague. This is a 2-year-old boy presenting with chest discomfort and shortness of breath. Initially, a chest X-ray was done, which revealed a large radiopacity in left lung field, saluting superior mediastinal border with gross tracheal deviation and contralateral shift of the mediastinum. CT scan of thorax was done subsequently, which showed pathognomonic findings. Here are CT scan images. What we can see here is there is a large opacity which is pushing the mediastinum contralaterally. The visualized right lung field is clear. Here are a few more images. What we can see is a very large left lung low attenuation mass, mainly involving the upper lobe and extending into the upper mediastinal fat plane with contralateral tracheal and mediastinal shift. No intrabronchial disease component was detected, although left bronchial branches were grossly compressed and non-traceable. Right lung was mostly clear, apart from mosaic attenuation in base of the lung due to air trapping. Here are the coronal images, coronal reformation of the mediastinal window. What we can see here is a large low attenuation mass. Here are few more coronal reformatted images. What we can see is a large fat density mass involving the most of the right lung, extending into upper mediastinal fat plane with contralateral tracheal and mediastinal shift. So the mediastinal window images provided invaluable diagnostic clues. Most of the mass was composed of fat, CT attenuation ranging between -45 to -140 Hounsfield units, and smaller areas of low density soft tissue elements. No microscopic calcification or dental elements were identified. Mass was smooth marginated and well encapsulated, but crossing midline anteriorly into contralateral hemithorax. Though intravenous contrast study was not done, plain CT did not reveal any obvious vascular encasement. No mediastinal lymphadenopathy or pericardial infiltration or effusion was detected. So provisionally, a radiological diagnosis of pulmonary teratoma extending into mediastinum was made. Subsequently, open lung biopsy was done, which confirmed the CT diagnosis. Here are the histopathology slides. The gross specimen of the histopathology report showed features of benign mature teratoma. Microscopic examination showed variety of cell lines in the specimen. So the final diagnosis was giant intrapulmonary teratoma. Teratoma is a common tumor of the mediastinum, but is rarely found in the lung. Furthermore, a mature teratoma seldom shows metastasis to the lung. Mature teratomas are the most common histological type of germ cell tumors, followed by seminomas. These lesions originate from the third pharyngeal pouch and present with variety of clinical and radiological features. Primary lung teratomas have rarely been reported since Moore's description of this entity in 1839. Germ cell tumors are predominantly found in gonads, while the anterior mediastinum is the most common extragonadal site. Our case is very rare, keeping in view the age of the child and size of the mass. Nearly one half of the patients have no signs or symptoms when the mass is initially diagnosed. Symptoms commonly present are chest pain, back pain, shoulder pain, or dyspnea, cough, fever, pleural effusion, or bulging of the chest wall. Hemoptysis or expectoration of hair, which is also known as trichoptysis, or sebum can rarely occur when the communication between the tumor and the tracheobronchial tree develops. Trichoptysis is the most common specific symptom. Symptoms can also derive from the pressure exerted on the surrounding tissue, for example, superior vena cava syndrome. Intrapulmonary teratomas are usually cystic and multiloculated, but may be solid, as in our case. Microscopically, mesodermal, that is bone, fat, and muscle, ectodermal, that is skin and hair, and endodermal, respiratory epithelium and gastrointestinal tract elements, are seen in varying proportions. Mature elements often take the form of squamous line cysts. Thymic or pancreatic elements may be seen in mature teratomas. Malignant pulmonary teratomas present as sarcoma or carcinoma with the presence of immature elements like neural tissue. In our case, tumor was composed of stratified squamous and respiratory epithelium, mature adipose tissue, cartilage, and connective tissue. Radiological findings to be noted are that IPTs are typically cystic masses, often with focal calcification. CT accurately estimates the density of all elements such as soft tissues, fluid, calcification, fat, and teeth. MRI is valuable in detecting the anatomic relation to mediastinal and hilar structures. Surgical resection is the treatment of choice, and radical extirpation leads to a long recurrence-free survival. These are the references. That's all for today. Thanks a lot for watching the video. We'll be back very soon. Thank you very much.